Here's a full review discussing fibromyalgia as an autoimmune disease, examining current evidence, hypotheses, and controversies. Fibromyalgia as an autoimmune disease, a full review. Fibromyalgia, FM, is a chronic disorder characterized by widespread musculoskeletal pain, fatigue, sleep disturbances, and cognitive dysfunction, fibrofog. Traditionally classified as a central sensitization syndrome, fibromyalgia has not been considered a classic autoimmune disease. However, recent discoveries have sparked interest in autoimmune mechanisms as possible contributors to fibromyalgia pathogenesis. 1. Classical understanding of fibromyalgia. Historically, FM is regarded as a non-inflammatory, non-autoimmune disorder involving central nervous system sensitization, abnormal pain processing pathways, neurotransmitter imbalances, e.g., serotonin, dopamine, norepinephrine, stress response dysregulation, e.g., HPA axis, genetic predisposition. It typically lacks serological markers, e.g., ANA-RF, and tissue inflammation found in autoimmune conditions. 2. Why consider autoimmunity in fibromyalgia? Recent studies have begun challenging the traditional model. Key observations include A. Overlap with autoimmune diseases. FM is highly comorbid with autoimmune conditions like SLE, RA, and Sjogren's syndrome. Many patients with autoimmune diseases have overlapping FM symptoms and vice versa. B. Presence of autoantibodies. Some studies have detected nonspecific autoantibodies in a subset of FM patients, including ANA positivity without criteria for lupus, antiphospholipid antibodies, antithyroid antibodies. But these are not disease-specific and their role in pathogenesis remains unclear. C. Immune dysregulation. Abnormal cytokine profiles, IL-6, IL-8, TNF-α, have been reported in FM patients. Altered B and T cell functions and increased mast cell activity have also been proposed. HAT3. Landmark evidence. Passive transfer model. Landmark 2021 study, Cambridge and Karolinska Institute. Serum IgG from FM patients injected into mice induced FM-like symptoms, including reduced grip strength, hypersensitivity to mechanical and cold stimuli. Mice receiving IgG from healthy controls did not develop these symptoms. Interpretation suggests that autoantibodies in FM patients may be pathogenic, supporting an autoimmune hypothesis. Counter-arguments and controversies. Despite intriguing data, several points argue against FM as a classical autoimmune disease. A. No tissue inflammation, no evidence of end organ damage or inflammatory infiltrates, normal CRP and ESR in most cases. B. Lack of specific autoantibodies. Autoantibodies, when present, are inconsistent and nonspecific. No antibody or antigen unique to FM has been identified. C. Non-responsiveness to immunosuppression. Most FM patients do not improve with corticosteroids or immunosuppressants. This contrasts sharply with autoimmune diseases like SLE or RA. 5. Current hypothesis. Immune-associated, not immune-mediated. The emerging consensus proposes that fibromyalgia may involve immune system activation, particularly via autoantibodies and cytokines, without meeting criteria for a classical autoimmune disease. This places FM on a spectrum between central sensitization and immune dysregulation, perhaps akin to ME/CFS, chronic fatigue syndrome, or mast cell activation syndrome. Clinical implications. Diagnosis remains clinical based on ACR criteria, no specific biomarkers yet. Treatment. No role for steroids or DMARDs unless another autoimmune disease coexists. Emerging therapies. Investigations into IVIG, B-cell depletion, e.g. rituximab, and anti-cytokine therapies are ongoing but not yet validated. 7. Future directions. Autoantibody profiling. Identify FM-specific antibodies if they exist. Immunomodulatory trials. Controlled trials of IVIG, anti-IL-6, or anti-B-cell therapies. Neuroimmune interface. Further study of how immune signals affect nociception. Conclusion. While fibromyalgia is not yet classified as an autoimmune disease, growing evidence suggests possible autoimmune-like mechanisms, particularly involving autoantibodies and neuroimmune crosstalk. However, the lack of inflammation, specific autoantibodies, and immunotherapy response continues to separate FM from classic autoimmune conditions. It may be best viewed as a neuroimmune pain disorder, an entity at the crossroads of immunology and neurology, deserving further study.